Dying is very, everybody handles it different. Everybody thinks they're going to handle it, with dignity and I'm going to be, and there, you get closer and you get that kind of freaked out fear.
Yes, and that's what we're here for. Like, we provide a lot of emotional support, whether it just be a listening ear, because the end of life, the concept of end of life does bring up angst in people. Some people are afraid. Some people are sad. Some people have unresolved issues.
Right.
Some people, we have to have coordinate conversations with family members to help resolve some things. We spend a lot of time looking at the patient and what's going on with them mentally just as much as what's going on with them physically.
The opinions expressed in the following program are those of the producer and not necessarily those of WKTV Community Media.
Hello, West Michigan, and this is Grand Tap Media Business TV. My name is Pamela Keim, your host. The spirit of the show is to introduce West Michigan to all the businesses, nonprofits, individuals that can help us thrive in our lives. Well, we're going to be talking about something that maybe some people feel uncomfortable about, or maybe they think they know everything about this company, maybe they've had a deal with them, or maybe it's for caregivers out there that are taking care of a loved one, a family, somebody, an aunt that is dealing with the end of life situation, and they are taking care of so much care, and they would really like some assistance or some guidance on how to do that. So we have a wonderful guest today. It's Wendy Kroll, and she is from Heartland Hospice, and she is going to answer some questions and some misconceptions that we might have about hospice and what exactly do they do. But I want to welcome Wendy to the show.
Thank you so much for having me. I appreciate it.
All right, so yeah, we talk a lot because we're both in the aging area, and I do interview a lot of people because it is a big deal, especially with the aging population that we're dealing with. I mean, pretty much everywhere. You can't go to any restaurant, you can't go to any event or whatever and see that there's a lot of, that there's a lot more population in that area. So then you're going to be dealing with people that will get to certain seasons of their life where they will need care.
Yes.
And they usually are relying on their kids, their families, their neighbors, their church. Mm-hmm. And it can become very overwhelming. And I know that because my dad had hospice, my mother had hospice, and we called you guys way too late. We were burned out by the time we called. So talk to us about what you do for in the hospice field, and what are some of the things that we need to know?
Sure, absolutely.
Before I pick up that phone and think you're going to be my lifeline?
Yes, I can be your lifeline. My role is a hospice care consultant. So what that means is just a fancy way of saying I talk to patients, I talk to families, other places in the community that would connect patients and families to a hospice type service, and I just do a lot of education. First step would be to have a conversation about what someone's goals of care are and what that might look like for them. So that's really what my role is in a nutshell. And what do people need to know about hospice? Well, hospice is...
Well, how about what is the real mission of hospice? We always think it's, we always see the images of them holding their people's hand at the end of life.
So
right?
many hands.
Yes. Well, you know what I'm saying, but that was
Yes.
what their goal, that was kind of what, and that's what's my thing, was they're going to be there. So let's start. What is the mission of hospice when people are like, we have hospice coming in?
Comfort.
Right.
It's comfort care. It's a whole different philosophy of care. It's a different mindset. So it's designed for patients with illnesses or conditions that don't have a cure. Often they have a prognosis of 6 months or less, and what they're looking at for that is comfort and dignity and making sure that their goals are voiced and maintained. And that's what our job is to make sure that patients are comfortable and remain wherever they want to be.
It's pretty emotional for I would tell you, when you get to that point where it's down to, like, we waited, way too long. And I will tell you that my dad, we did not. My mother, we did. I think you were with us for, I don't know, maybe a week, 2 weeks. Mm-hmm. And we would have known, just for a listening ear, right?
Yes.
They come in, families there 24/7, and they have no idea what should be happening. right? And what is
Yes.
available.
Yes, and you're not alone. I
Okay.
think the statistic is that 50% of hospice eligible people only utilize the benefit for 24 hours or less.
Yeah.
But if you knew how many people would come onto service, patients and family members, that say, I wish we would have done this sooner.
You hear that a lot?
All the time.
Okay.
All the time, yes.
Okay.
And no one wants to talk about hospice. It can be an uncomfortable subject, but once people are open to the conversation, I mean, sometimes I meet with people and they're not ready. I met with a lady who was on dialysis, and she asked me straight up, like, how will I know when I'm ready to end dialysis? And I said, well, if you're asking me, you're not ready.
Okay.
And that's okay. But I would encourage people to just have conversations early, even maybe before you're ready, just so you know what options are out there. It's a whole different treatment plan. It's a different mindset.
Okay, so you're dealing with what family? Who makes those decisions?
Depends
like,
on
you know, when I mean, hospice came to the home, and we had that. You know, I was involved, but my family members that were in charge of the health situation. That conversation, what does that even look like? You go through you take over the whole care. What does that look like?
It looks a little bit different for everybody. Sometimes I meet with a patient first, and the patient will decide, like, is this something I want to explore? Is it not? And then if they decide yes, it is, then they're asking me, like, how do I bring this up with my daughter? And sometimes it's the opposite. Sometimes it's the kids that are like, oh my gosh, I need assistance in the home. I need help. My mom wants to stay at home, but I don't know what to do. I don't know how to help her.
Yeah.
I need some support. How do I approach my mom? So it really it's very individual. And I've had family meetings where it's just a patient and a daughter. I've had family meetings where there's 12 people in the room.
Oh God.
It just
That would be so scary. I mean, not that they're into, but they're all like, pretty much what's the best care and how is this going to affect my life? Because we all had to work.
Yes.
When my mother, that was 98, so that's a long time. We all were working. We all had children. We all had families. And it's like, okay, who's taking care? Because it was off the table that she wasn't. But you do have facilities too, right? No?
So
Do people go into any of those, or is it always home?
80% of hospice care is usually provided in the home, but
Okay.
that can also be wherever someone calls home. So one of the misconceptions about hospice is that hospice is a place. Hospice is a service that's provided wherever that care is needed. So patients who stay at home have support systems, family members, private duty caregivers that can help them take care of their custodial needs. I think another misconception about hospice is that we're 24-hour care, which we're not.
I would say when I did meet with them, and I said, you're not going to stay, and so we could go to the grocery store or whatever, and no, that's not what we do, right? That was a misconception. I was like, I would just want to go take a shower and not have to. I mean, they would help in that area.
We
because
do that.
You know,
So
they do that, but I was thinking we could go home and make dinner for our kids and come. No, that wasn't. I was totally wrong.
If the patient needs to be supervised 24 hours a day, it just depends on the patient's needs. It sounds like if a patient can't be left alone, yes,
well, by
that's
the time
the
we
case.
called you guys, it was 24-hour care.
Yes,
It was,
yes.
So they weren't leaving the bed, so you had to take care, and that's a very exhausting care.
Absolutely.
Right.
Yes.
But are all the hospice that come in? Are they all nurses? Are they all qualified to look at everything and be able to assess? Is that something that they do?
So the first person that a patient would see would be the registered nurse. And the registered nurse would do a full set of vitals and assess the patient and look at eligibility. Does this patient qualify for hospice? And then their care would be managed by an RN case manager. And that
So
would
who
be
qualifies?
the
What is the
medical director, the nurse. They have a conversation about that. And Medicare gives us a list of guidelines that we look at to see if someone is eligible for the service. So the first step is seeing, does this patient's goals of care align with the hospice philosophy? And if so, then we would do a nurse evaluation and then determine, does the patient qualify for hospice? And it's different based on the diagnosis. So that's what the first step is. Then your care is managed by an RN that would come in a couple times a week and look at your symptoms. And it's different than other types of care. because of the questions that they ask, but they're not the only ones that are coming in the house. There's a social worker that's involved with emotional care.
This is from hospice? This is the team of people that are coming in?
Yes.
Okay.
There's a chaplain that's going to come in and look at spiritual care.
Okay.
There is aides that can help with taking a bath or clipping toenails or doing a bed bath if it's like your mom who's bedbound. Whatever the patient needs. Any sort of hands-on hygiene care is what our caregiver support is supposed to provide.
Yeah, wound care if they have
Wound
like a
care,
wound.
yes.
Yeah,
Catheter care. We're available 24 hours a day, 7 days a week if you have something that pops up in the middle of the night. Because our goal, again, going back to our mission, is comfort. So if you are the caregiver,
Right.
you know, of course we're caring for the patient, but we're helping you too. Like, we're empowering you through education and hands-on training for how to provide care for your loved one.
Yeah.
Because not everybody's a registered nurse, and
No.
you're doing, you know, some of our patients have some high care needs, and we do a lot of education about disease process, what to expect, things to look for, you know, and what is it that you can be doing to make this person comfortable when we're not here. There's all sorts of different ideas that we have.
So
to
what would
connect.
qualify? You said there's some things, so name a couple things that, like I mentioned that my mom, you know, we waited too long. Once she was totally bedbound and we were 24-hour care and we just couldn't, she was dead weight. We couldn't even, it was hard, right? Everybody understands that who's dealt with a loved one that's leaving us, right?
Yes,
That's their
yes.
body's leaving. It's just, it starts to, you know, not function and whatever. Anyways, but what would qualify me? How far back should we have gone? I mean, what are the, you know, could we've gone back 4 months, 3? I don't, like you said, you have to be 6 months.
Yes.
Right? But how do you know as a person, as a daughter, it's like, okay, I think when the doctor says, you know what, I don't think she's going to be here for, do we have to rely on his?
No, I think if you, it's a hard question to just give you a point blank answer, because whether someone qualifies for hospice or not depends on their condition and kind of their whole picture. For example, you take a dementia or not a dementia, an Alzheimer's diagnosis. You look at Alzheimer's and you can live with Alzheimer's for a long time, many, many years. And because hospice is a government benefit, that's where I think hospice gets the Grim Reaper reputation, is because of that 6-month prognosis. Like, a doctor does have to say, if this patient's disease continued to take its natural course, it wouldn't totally surprise me if this patient weren't here in 6 months. Do we have patients that live longer than 6 months? Absolutely. Does your benefit cut off after 6 months? No, it does not. You have to continue to qualify for the program throughout care. So people have graduated from hospice also.
I've seen that done too.
So to answer your question about, you know, with an Alzheimer's diagnosis, Medicare gives us a menu to look at of different symptoms and what's going on with the patient. And, you know, basically to qualify under an Alzheimer's diagnosis, you have to be really not speaking more than 6 words that make sense strung together and incontinent of bowel and bladder.
Yeah, that's a big one.
Yes,
Yeah.
so, but it looks different for CHF, it looks different for COPD, it looks different for cancer. So what I usually try to coach people on is looking at early indicators or things that might at least trigger a thought about hospice, because people aren't ready to just jump right into hospice until they've kind of thought about it for a while.
Well, and it's hard to bring that conversation up with the
Absolutely.
person that's not ready. Like, you know, that your job, you know, Mom, you're not going to be, you don't understand. I didn't even know how to start that conversation.
You're not alone. You are not alone.
I mean, Mom, we think you're going to be gone, and you know, we want to, and then they feel like you're burned out because you're dealing
Absolutely.
24-hour care, and then it's not like you don't love your mom, but you still have your physical needs, and you have your you know, your whole family to take care of and work. It's just like that's what happened to my dad. He felt so bad that we were helping him all the time, and he felt like we were overwhelmed, which we were. But it's not like I didn't want to do it. I just wanted to be able to figure it all out. So hospice was a great way of coming in and, okay, this is what needs to get done.
Yes.
Right? You
Yep.
kind of go through the plan, right?
Yes.
Like, you don't want my dad laying, you need to move him once in a while in the bed because the bed's so, there was all kinds of things that you take for granted that he did on his own, but he isn't doing on his own anymore.
Yes, and if you don't, then you get skin breakdown and condition
And that's another
worsens.
lesion.
Yes.
So what are some other misconceptions that people have when you're having that meeting with them? They're asking that, maybe some people should be picking up the phone sooner, or what, that make sure this is happening.
Yeah, well, other early indicators would be like weight loss. Someone's not trying to lose weight, they're just losing weight inexplicably. They're bouncing back and forth to the hospital. Maybe they should go to the hospital, but they don't want to go to the hospital.
Right.
Any sort of, symptom that's popping up that's not managed well. Shortness of breath, they're having a really hard time breathing. You start to notice some of those symptoms that just looks like overall decline. In a facility, I always, talk to nursing homes folks about looking at their patients and residents who used to come down for activities and they're just not anymore.
Right.
They used to do X, Y, and Z and they're not. They just seem to be sort of withdrawing. Overall decline. It's time to start thinking about it and maybe having a conversation, because again, our goal is comfort, our goal is quality of life, and you want to maximize whatever time you have left with your loved one. So hospice is just an added layer of support.
Okay, and hospice, once you have hospice, they take over your care,
So-
pretty much?
So that's kind of a misconception, I think.
Okay, that's a good misconception.
Like I can never see my doctor again. Patients are always the driver of the bus.
well,
like
you're just
you-
kind of
yeah.
looking at the notes of the doctor, aren't you? And what medications they are and what they need to get. No? Do you?
Yeah, so the nurse would come in and do an evaluation of a patient and determine, and that evaluation is lengthy. And we're looking at the patient, we're taking vitals, we're looking at information that we have from clinical staff that are detailing diagnoses that they have. But we're drawing a lot of our information from an actual assessment. Sometimes we have a patient get up and walk and see what happens with their shortness of breath. We're drawing a lot from family members of things that they're noticing, things that aren't on paper.
Right.
So all that's kind of part of the evaluation process, to look at that patient as a whole. What does this patient need? Do they need this level of care? And if it's appropriate and we sign them on, then that RN is managing all their symptoms. So we do develop a plan of care with the patient. So what that care team looks like kind of depends on what the patient chooses. The patient is always at the center of the care. So I think people think hospice is going to take over, but we don't. We do a lot of education and we help support, but we don't tell anybody what they have to do. We don't tell them what their care plan is going to be.
Yeah.
We collaborate with that patient and their family in terms of what the patient needs.
Okay.
For example, the nurse is definitely a requirement from Medicare, but there are other disciplines that I mentioned, like the aide and the chaplain and the social worker, and sometimes people don't want those added services. They think that's way too many people coming in and out of my house.
They do feel that way.
I don't know if I want all that. You don't have to have all that. Other times, once they say no to all that, they say yes just to the nurse, then they come in, their care needs increase, we can always add services on later. Conversely, I've had people get all gung-ho and they say, yes, I want all the services, and then they're like, oh my gosh, this is a lot. And we can back it down. It's very fluid. Like, your care plan is very fluid based on what's going on at that time.
So you deal with the spiritual,
Absolutely.
because people are going through some difficult times. Maybe they need some reconciliation. Maybe you need someone to talk to, because dying is very. Everybody handles it different. Everybody thinks they're going to handle it, with dignity, and I'm going to be. And there, you get closer and you get that kind of freaked out fear.
Yes, and that's what we're here for. Like, we provide a lot of emotional support, whether it just be a listening ear, because the end of life, the concept of end of life does bring up angst in people. Some people are afraid. Some people are sad. Some people have unresolved issues.
Right.
Some people, we have to have coordinate conversations with family members to help resolve some things. We spend a lot of time looking at the patient and what's going on with them mentally just as much as what's going on with them physically, because it's a huge part of the care is the mental part too.
And you guys are kind of not a buffer, but you know what I mean. You can listen without any really emotional, besides
We don't have all the
empathy.
family history.
Right, we don't have all the
Yeah.
family history, and we don't have that, and I think that's kind of what happened. I will tell you that's what happens. You want to be able to say what you want to say, and then you gotta, and I always wanted just to I'm that type of, I'm kind of like you, I'm a reconciliationist. It's just let, I want to help you through this, Mom or Dad, and get through this. Don't worry, we'll be fine. And, so I was the one that was sitting on the bed talking to my dad, and the other friends were trying to get everything done. And but I knew that I wanted that time with him, right?
Yes.
We all want that time with him. So, okay, so what other things we missed here? What is one of the things that, we haven't talked about some other, so Medicare care takes care of this, right? Or unless you're on Medicaid, too?
Both, yes.
Both
So
will handle-
Medicaid, it's
you
a
gotta qualify.
fully Medicare covered benefit. Medicaid plans cover hospice too, and most commercial insurances. We do see a lot of younger patients. I know we were talking about aging population that would fall under Medicare, but there are a lot of younger patients too that are of working age, and they have commercial plans, and most insurances have a hospice benefit.
Oh, they do? That's
but,
great.
But even if they don't, everyone deserves proper quality end-of-life care, and there are avenues that people can go about to get that too, regardless of their ability to pay.
Now, do you go in nursing homes and assisted livings? And I know assisted living you might, but a nursing home?
Yes.
Considering they have stuff, but would that be something that you would do too?
Absolutely. So you mentioned your mom and her care needs, and that you and your siblings kind of stepped up to the plate to provide that. Not everybody has that level of family support, or even if they do, their families are working or busy, or they have other things going on and they don't have that ability. So hospice care is meant to be an added layer of support to focus on end of life and comfort. But they don't do like someone's day-to-day needs. So if you as a family aren't able to manage that, or the patient can't manage it themselves, that's where you would enter into like an assisted living community or a nursing home that can help provide some of that day-to-day care. But the hospice care would be the same. So we would still come to an assisted living facility, we would still come to a nursing home and provide that added layer of support for the patient, for the family, and in those cases, for the staff as well.
And you decide if it's 1 or 2 times a week that you come in and review what's going on and how the patient has changed.
Absolutely.
And then answer any questions that would be, because I've dealt with, and they did really well at answering our questions and addressing what was going on in our lives.
Yes.
Which was completely, you're mourning and you're overwhelmed, and it's just like you're on this adrenaline rush for weeks. It's always about the person that's going through this, what's going on, every time the phone rings. You know what I'm saying? You're always on this high rush and stuff. So it was really comforting to, some nights I sat and talked to them for like an hour or so. And when they were there, man or woman, would have came in, and I was like, it was very nice. I always looked forward to having, if I was there by myself, the guys show up and like, oh good, hospice is supposed to be here.
Yes, a little sense of relief.
All right, well, so what is one thing that everyone is still, at end of life care that you want them to know? I said you were going to answer this one.
Yes.
So everyone understood about the end of life care.
That it doesn't have to be a big scary thing. It's just a conversation. Like, we're going to talk about your goals of care. We mentioned earlier, so many people wait. It's a benefit that you've paid into your entire life. It's something that every working person, there's a little chunk that comes out of your paycheck toward this care. People wait. So many people wait. And it's just a conversation. The first step to any sort of hospice care is that initial goals of care conversation. And whether it's appropriate or not, it just kind of depends on what that conversation develops from. So the one thing I would just say is don't wait.
How does the patients, I know you guys are great, but I meant is it family, do you see the more of family need being comforted during this time, and then the patients knowing that they're going to be leaving their family? Does that make sense? Like they're going, comfort.
Yes, there's a lot that we do in terms of having those conversations, some legacy work. We're making sure that when our patients that are on our service pass away, all the T's are crossed, all the I's are dotted, and all that's left for that family to do is grieve the loss of their loved one. And then there's bereavement care on top of that we follow our patients for over a year after the patient has passed away.
Yeah, my dad loved that part too.
To get through all those firsts,
he was
right?
alone. He was all alone.
Your first Mother's Day without your mom is really hard, and
the first time I walked in the house and there was the bed was gone, because you have the hospital bed there.
Yeah.
But you walked in and there was just one chair in the living room and a couch. and he took my mom's chair away that
Mm-hmm.
for their 40 years, right? I walked in and I just stopped in my tracks. And then, but what he liked is that he was able, you guys contacted him. Sometimes, you know, right away, maybe a week or so, I can't remember, he stopped by, so he was doing, but gave him support and kept him in, you know, your radar
Yes.
for about a year, and he would always tell us too, yeah, I talked to such and such on the phone, they were just checking up on me and see how I'm doing. Because, you know, we are grieving too, when you're forgetting, and you're always trying to keep dad or mom perked, trying to get her through the next thing.
Right. It's a covered thing. It's a covered thing. It's so much support for you as a patient and your family. Hospice is a gift that you give your family. It's a gift that you give them, because if you want to be at home or wherever you call home, we empower the people in your life to help you do that.
Yeah.
And that's our whole goal, is to make sure you're comfortable, you're treated with dignity and respect, and all of your wishes are maintained.
So when should you, okay, so we said about if you think they're end of life 6 months, should people that are caring for their parents and they realize they're, you know, getting very close to not dying, but they're going that season, should they be checking, or should they just wait until they have a, you know, we're getting to the point where, you know, you're home and you realize mom's not getting, she's not thriving, she's failure to thrive.
Yeah.
She's got, when do people start saying, okay, we need to start planning? It's like planning, doing your trust and doing your, you know, who's your resuscitation, all the stuff you have to have, all of this in place. When should hospice be a conversation?
I would say hospice should be a conversation anytime you notice just decline. You notice overall general decline. Someone is struggling to do the things that they used to be able to do. It's an appropriate time to at least plant the seed for hospice and have a conversation about it.
Okay.
And I mean, I've had many people reach out. We had a patient on our service who wanted the service for his mom. And I connected with her, and she didn't qualify for the service. She didn't want the service, but it's just a conversation, right? Like, it's not, I promise it's not a timeshare sale.
Yeah, really.
It's just a conversation, and all you have to do is reach out by phone, and it's
And how
a
do they
simple
do
thing.
that? Good point. We're going to jump right into that.
Yes.
So how do they reach you to start that conversation and say, you know what, it's my mom and my dad and my aunt, my neighbor.
Yes, I always give out
qualified.
my cell phone number. It's,
You know?
you can call me or text me, and we can set up a time to talk. Sometimes people like to talk over the phone. Sometimes they want to text first. Sometimes they want to meet in person. I'm open to all of it. My cell phone number is 616-286-2587. You can call me or text me anytime.
Yeah, you might remember that. When I was going through that, it was just like, I just wanted somebody to, and this is going on, and this is, you know, gosh, it was just it's a big deal, especially when you're watching your parent now. I'm getting,
It's hard.
I'm up here. I'm lost. I went through a lot of
You're at the
aunts,
top
uncles.
of the pyramid.
At pyramid. I'm now the head. I always tell people we're the next. I go, nobody to blame above us, and nobody. But to see them leaving and going, it's been difficult. But yeah, I've dealt with you guys, and it's been a wonderful experience.
Good.
And like you said, my only regret is I wish we'd have called. We didn't do that mistake with my dad. We definitely did it with my mom. My first, and that was 20 years earlier. But it was just like, why didn't we call them sooner? Just so somebody knew what they were doing. That's what we were looking for.
Yes, we can help you.
All right, we want to thank Wendy Kroll
so
for
much.
being here today. We really appreciate it. From Heartland Hospice, like I said, check them out. She's left her contact information if you want to have that conversation. This is Pamela Keim from Grand Tap Media, and we will catch you next time. Take care, everyone.